name's Paul Townley. I'm a physiotherapist of many years' experience. What I'd like to do in this serial of blogs is give you some idea of how to incorporate your practice with evidence-based practice. It's something that has come very much to the fore, using evidence-based to support our treatments and to enhance our treatments. Maybe I can start with giving a little bit of my history. I'm originally from the UK. I did both my degrees in the UK, and I worked in the health service, and then also worked in professional football before becoming private practitioner, and then also working with the military. When I first started my career many years ago, just after the first ice age, I was starting to see things that were coming through, were becoming more evidence-based supported. And this is to say that at university we were being encouraged to look at the research and use it within our practice. One of the problems is that evidence-based practice has become synonymous with research-supported practice, which is a different thing altogether. Now, before you stop and flick off to YouTube and watch your favourite music star, or whether Spetsnaz is stronger than a US Marine or something like that, I'm not going to fill these blogs up with all the research models, the research design, statistical analysis, null hypothesis, or levels of significance. They're relevant, they're important, but that's not how we are going to be able to use it in the clinical setting. And one of the great things about my experience was it gave me a very good perspective of how evidence-based practice and how research-supported practice can fit in with everyday practice. One of the things was, as I was saying, is I left university and this was becoming a big thing, but it was still on the back of a lot of techniques and methods that were adopted or used by osteopaths, chiropractors, massage therapists, physiotherapists, a whole gamut of techniques that we were using. Some of them had support, some of them didn't, and they were very popular thing to do, and evidence-based was starting to come in more and more. Now, evidence-based is very important because it elevates us professionally. If we're talking to other professionals, we're going to be taken a lot more seriously if we can say, yes, we have this support. It elevates us clinically because we can then use it to help us address problems within our treatments and how to improve our treatments. But one of the things, sadly, I've seen over the last 25 to 30 years is that evidence-based practice is becoming a guruism. One of the things that used to happen was somebody would go on a course, they would learn a particular technique, they would come back and they would use that technique for the next 2 or 3 weeks, and every patient in the National Health Service was getting treated with the same particular type of course, and they were becoming gurus within their own right. And evidence-based practice, or evidence or research supported practice, was meant to stop that, but it's now being used in exactly the opposite way, and is being used as the new guru, which is a bit of a shame, because we do really need to be able to use it just to help us. It shouldn't be used to demean or denigrate a particular method, and it shouldn't be used to as an excuse not to do something. And in a lot of cases, this is what is happening. NAT does some absolutely brilliant courses with many techniques, and most of it's supported somewhere in the literature, and therefore we can use that fairly comfortably. But unfortunately, some of the gurus of the evidence-based practice methods have started using their research evidence or lack of research evidence to turn around and say, oh, these methods don't work, or that's not worth using, and because it's not written, I'm not going to use it. I remember, like I said, I qualified just after the last ice age, but as we were entering the bronze age, I was already working. And I remember working with one bright clinician just fresh out of university who came up and said to me, well, if it's not evidence-based, I don't use it. To which one of my older colleagues turned around and said, well, you're not going to be sitting around here all day, because we don't accept that. And I think you need to look into it a little bit more. And that's to say that just because something doesn't have an evidence supporting it, or a research-based evidence supporting it, it doesn't mean that it's not worthwhile. One of my favourite quotations is by a cosmologist called Martin Rees, and the quotation was popularised by Carl Sagan, another cosmologist. It's very, very relevant in healthcare settings, and that is absence of evidence is not evidence of absence. What does that mean? Basically, just because we don't know something, it doesn't mean that it doesn't exist or that it doesn't work. In fact, in my humble opinion, and I imagine most researchers would support me in this, research basically shows us what we don't know, and that is why people carry on with research and strive in research to continue to improve their knowledge and progress and progress and progress. Just take any aspect, whether it's medicine, space travel, anything. We learn from our mistakes, we improve, and that's all based on the research. Bear in mind that this idea is the same throughout all professions. We know less, or a lot less than we think we know, and therefore we carry on using research to improve our methods and improve the way we're working. But we have to be careful, and very, very careful with this. One of the things that concerns me in research-based or research-supported practice, as opposed to evidence-based practice, is kind of how we use it. Now, there's a couple of things I want to try and highlight here. First of all, evidence-based practice is not research-based practice. Research-based practice is an element of evidence-based practice, but they've been basically used together. Evidence-based practice is now the umbrella term for research-based practice. Research is somebody carries out a piece of research using good research methods, good research design, a good hypothesis, and they come up with a particular answer that supports their hypothesis. But evidence-based practice, and I got this from a course I did on the shoulder by a guy called Jeremy Lewis, is actually evidence-based practice is like a triangle. It's made up of our clinical reasoning, empirical evidence, which is the research part of it, and our clinical practice and experience. And those three elements make up the evidence-based practice. An example of this could be, you may be treating somebody with a back problem. You could be using a whole range of methods. You could be using trigger point release, you could be using manipulation, you could be using cupping, you could be using a whole different types of treatments and a selection of methods at a different time. And because you want to remain current and a decent practitioner, you consider which evidence is available. And you read an article that may come from a particular time, from a particular journal. And let me give you an example, a very vague example. An article says that treatment A, when used in 40-year-old men during a rainstorm, does not help back pain. Great, that's what it says. Treatment A, when used on 40-year-old males during a rainstorm, doesn't help. And that's all it says, unless the article said something else. But more often than not, they have a conclusion. It is a mistake to try and apply that to every single thing afterwards. It doesn't mean that you can't use it for a 20-year-old man in a rainstorm or a 55-year-old woman in a rainstorm. It means it doesn't work for a 40-year-old man in a rainstorm. But the problem is that often people will take that and use it as an excuse not for using treatment A, which is not a good idea, because it's a shame, because we could be not using a particularly good treatment technique when we could use it. Absence of evidence is not evidence of absence until somebody finds out that it doesn't work in a 55-year-old woman during a rainstorm. Not that I can really understand why anybody would be working in a rainstorm, but there you go. one of the things is that we should always consider what we're doing, how the evidence supports what we're doing or not support what we're doing, and not use it as an excuse not to use it, because basically we're doing ourselves and our patients a disservice. This is actually quite refreshing, because if you think about it, you could be treating somebody and things aren't going the way they should go. You could then say to yourself, well, hold on, I've got a 40-year-old man and it's raining outside. Maybe that's the reason it's not working. Perhaps I should try something else. It doesn't mean that, oh, I'm not going to use this at all and I'm going to apply it to everything. It's actually really quite refreshing and helpful to us to know that. And I've done that. I've found pieces of work that have said that a 40-year-old man, it doesn't have this or doesn't have that or it doesn't work. I don't use it with them. I'll try something else. It helps me move on quicker, helps me become a better clinician. It comes back to evidence-based practice is not just research-based practice. Research is one element of evidence-based practice. In my opinion, in other people's opinion, it's worthwhile looking at that. Not everybody's going to agree with it, but your clinical experience, your clinical reasoning, the work you do, the amount of courses that you go on, how much you study, how you utilize one particular method with another particular method in your clinical practice, all of them are relevant. They may not have empirical research-based support, but they're useful. And then along comes a piece of information that is empirically useful, and you can put that in and slot it in and build it up to help the picture of your overall treatments. One of the things that's imperative, really, really important to do is not to cherry pick. That's not to say we go around running around, don't pick any fruit or anything like that. That's always good for us, eating fruit. However, cherry picking articles in different ways can actually be quite damaging, or at the very least not very useful. Sometimes we cherry pick an article to suit a way we want to work. Sometimes, worse still, we cherry pick an aspect of an article or part of an article to support the way we want to work. Again, I will use analogies of people I worked with, and obviously I'm not going to say names, but there was a time that I worked with somebody and he took an article and said, oh, that article says that only exercise helps in shoulder problems, for example. The actual article, and he quoted the name of it, the actual article was written by a friend of mine, and he didn't say that at all. He actually said that the article was very useful with the actual treatment was very useful using manual therapy and exercise in a group setting, and they were both very helpful. But this colleague of mine wasn't particularly keen on manual therapy, and so used one part of an article to basically support his argument, which was the wrong thing to do, totally wrong thing to do. This is an example of personal bias. He doesn't like doing manual therapy. He prefers group settings, prefers exercise, which is all well and fine. That works for him. Every clinician has a method or a way that they work and they enjoy working, as do I, as does everybody. But the idea is not to just take a particular research article or a particular part of a research article and use that as a reason not to do something else. If you want to work in a particular way, by all means work in a particular way. But be aware that there may be other methods that you could utilise. That's an idea of personal bias. Another thing could be like the professional or institutional bias, and I'm going to come on to that in a bit when I give you a good example. There have been cases where, because of financial reasons, research had a certain bias to it. Commercially, people were sponsored, and so therefore they skewed their results or their conclusions to suit that. And an equal one is institutional bias. If you're in a very big setting, say for example in a large health service or something like that, or working for a big insurance company, and they want to save money, it's very tempting to use elements or articles or aspects of an article to support the area that could best save money. That doesn't mean it's right, it doesn't mean that it doesn't work, but it doesn't mean that it's the best situation. So one cannot cherry pick the things that they like. You need to be aware always what you're doing and why you're doing it. Okay, as I just covered a little bit about cherry picking articles, how can we so basically use the best research, empirical evidence? How can we use our best clinical reasoning and our best practice? Well, first of all, don't cherry pick. Be aware of your personal bias. Be aware that there may be an institutional or commercial bias in any said article. We do that by critically reviewing, looking at the reading the article, looking at the evidence or the topic with an open mind. Keep an open mind. Look at the article, review it, read it. Consider, does this work for me or doesn't it work for me? But if it doesn't work for me, why doesn't it work for me? Am I doing it because I really don't fancy it, or because it really is something that I'm not going to be good at? In which case I can then go on and do a course like the NAT courses to learn how to do those techniques better, in which case I will maybe be a lot more effective. Don't write off a study just because it's an old study. Don't write off a study just because it's a case study. There's very often, when one gets into research methods and things like that and critically reviewing, if that's your thing, then go and read some books on it. I'm not going to try and teach you how to do research methods and things like that. I did my master's, I had to do some research for it. Honestly, I prefer being a clinician, and that's the reason I work as a clinician rather than carrying on and doing my PhD. Not that I didn't have room to do the PhD, I just simply, that's not my thing. But there were many articles that may have come from many years ago that are very, very useful. There are very good areas like Cochrane reviews, Pedro and things like that give you a good idea and a good database, and you can take those articles and they do a lot of the work for you. But again, bear in mind that maybe some of those databases like Cochrane have particular criteria in which you're going to work, and that's fine. But sometimes they may take a particular research article and say, well, we're not going to include that because it doesn't have enough people, even though the design and the model of the research was brilliant, but it didn't have enough people to fit in with their review, so they put it to the side and it doesn't get used, and that can skew what their review may come out with. However, Cochrane reviews, Pedro, which is a database for physios, there's a lot of them out there, Medline, things like that. They're all very, very good starting points to find literature, look at it, consider it, read it. You don't have to read every single thing. Often review articles can be quite useful. And that's the other thing. Consider the type of article. Is it a research, pure empirical research article? Is it a review article? Is it an opinion article? What's the difference? A research article, let's say for example, one could say, if somebody did 500 squats, it will make their legs stronger, and they check that and they measure it against somebody who didn't do 500 squats and come up with a piece of information. That's a research article. That'd be very useful. But you might not be able to do that in your clinical practice. A review article may take several different articles to do with knee pain and find that 500 squats is the optimal idea for strengthening and improving knee pain. An opinion article may turn around and say, well, actually I don't agree with that, and they may have their reasons for saying that. So consider the type of article, what you're going to do with it, and how you're going to use it. Okay, what I'd like to do is just give you an idea of when to use and when not to use, or when a particular piece of research was useful or not useful. In 2016, there was an article published in the British Medical Journal by Bryson and et al. And another group of researchers on ankle sprains. And basically they looked into whether a standard treatment giving advice on rest, ice, compression, elevation, the usual things for an acute ankle injury, along with some advice on gradual weight bearing after a period of time, along with analgesics, was comparable to a physiotherapy regime. Obviously what happened was the results came out and they said there was actually no difference. So what could be used from that, and what can be taken from that, is that basically somebody goes to a doctor, gets given some tablets and some advice, and gradually gets back to standing on their legs, and it's just as good as if they went to a physiotherapist. Now, there was a problem with this. Obviously, with the physiotherapists who didn't agree with it. But the thing is that when you've got an article coming out of a very established journal like the British Medical Journal, and it had a case study of 500 participants, it's a pretty large case sample, and it says something like that, the tendency is to go with, okay, that's what we do. We'll just go to the GP. We won't bother with going to physiotherapy or chiropractor or massage or getting treatment. And the big problem with it was that the physiotherapy regime that they suggested was basically going to see a physiotherapist after a few weeks, and with giving exercise sheets and some things that it didn't fully utilise or explore what a physiotherapist would actually do and how they would work. There were elements of it that were useful, and we know that they're useful, but they didn't go into it in enough detail. And one thing that physiotherapists really try to do is try and promote the healing and the recovery process as quickly as possible, and get somebody back to the optimal point that they can work and train in the earliest possible opportunity. Now, there might have been some institutional bias, I can't say, but let's be honest, if you're talking about the British Medical Journal, maybe there were people in the National Health Service that would prefer that you didn't have to go to physiotherapy, because in the end that may cost money. I don't know, I can't say that, and I wouldn't say that. But there may have been an institutional bias, or there may be an institutional reason for supporting that article. It would save somebody going to see a physiotherapist. But the main thing about it is that the bulk of the literature prior to that does not support just doing that. When regards to physiotherapy, it's not just an exercise sheet and a few exercises at a particular point. The bulk of the literature, even up until quite literally a couple of months prior to this study being carried out, was saying that manual therapy and a proper exercise regime applied at the right time, at the right point earlier on, is far more useful and far more effective, and will promote healing and get somebody back into their sport or normal way of life than not doing it. The timescale is important. It's fair enough, but if you've got, say for example, I think that the results were saying something along the reason that, okay, 88% of people are going to return to normal with a grade 1 ankle sprain. But somebody who's got somewhere on the borderline of grade 1, grade 2 ankle sprain, and they can't get back to normal for 6 or 7 months, that's going to make a difference to them, particularly if they're a sportsman. There isn't a one-size-fits-all package to anything. We have to be aware that whatever we're going to do, we are using different techniques. Sometimes they work, sometimes they don't work. And that's the important thing, is that was a relevant article, it was useful, it was very well supported, it was a credible journal. All the things that one would look for in a proper critique and a proper literature review. But also there were things that were not included in it for whatever reasons. And that may have been less helpful to somebody with an ankle sprain. Basically, what I'm trying to say, the outcome is very important. It's nicer, it's better, as I said earlier, to have some sort of empirical evidence that backs that up. We don't always have that. Our evidence-based practice is not just from empirical research. It can be from our clinical reasoning. It can be from our clinical experience. Those three elements give us a very good idea of which way to progress, how to treat our patients, how to promote the outcome quickly or less quickly. The last thing you want to do is take a piece of evidence that says X and use that and cause some damage, or maybe not allow somebody to get back to a sport or get back to working day to day. So we use all three elements. Again, our clinical reasoning, our research, empirical evidence and our clinical experience to help us come to an evidence-based practice, which is our best practice for a patient. We use our articles to help us, we use our experience, and we use the courses that are available to us, and there are many of them, that give us another little element, another piece of the picture, another way to treat, another way to help our patients, which is basically what we're after. It may be quicker, it may be slower, it may be according to the patient. What I would like to do, and I hope you will find this blog as an introduction for a reason to incorporate evidence-based practice, not just research-based practice, evidence-based practice, often gleaned from review articles, to help you move forward and maybe support some of your actions and methods that you're going to use.